Gout. Gouty arthritis is a defect in urate metabolism with 90% of cases in men. This can be from overproduction or underexcretion. Overproduction. 1. Idiopathic. 2. Increased turnover of cells. Cancer, hemolysis, psoriasis, chemotherapy. 3. Enzyme deficiency. Lesch-Nyhan syndrome, glycogen storage disease. 4. Ethanol. Underexcretion. Renal insufficiency, ketoacidosis or lactic acidosis, thiazides and aspirin. Presentation. Look for a man who develops sudden, excruciating pain, redness, and tenderness of the big toe at night after binge drinking with beer. Fever is common, and it can be hard to distinguish the initial gouty attack from infection without arthrocentesis. Although the metatarsal phalangeal (MTP) joint of the great toe is the most frequently affected site, gout can also be symptomatic in the ankle, feet, and knees. Chronic gout tophi. Tissue deposits of urate crystals with foreign body reaction. Most often tophi occur in cartilage, subcutaneous tissues, bone, and kidney. They often take years to develop. Uric acid kidney stones occur in 5% to 10% of patients. Long asymptomatic periods between attacks are common. Tophi can occur anywhere in the body. Diagnostic tests. The most accurate test is aspiration of the joint showing needle-shaped crystals with negative birefringence on polarized light microscopy. The white blood cell count on joint fluid is elevated between 2,000 and 50,000 per microliter and is predominantly neutrophilic. Because gout can look like an infected joint with redness, warmth, and tenderness, it is essential to tap the joint to exclude infection. Uric acid levels elevated at some point in 95% of patients. A single level during an acute gouty attack is normal in 25%. Acute attacks are associated with an elevated ESR and leukocytosis. X-rays, normal in early disease. Erosions of cortical bone happen later. Treatment. Acute attack NSAIDs are superior to colchicine as the best initial therapy of acute, painful gouty arthritis. Corticosteroids by injection in a single joint or orally for multiple joints are extremely effective. Note steroids, e.g., triamcinolone, is the answer when no response to NSAIDs. Contraindication to NSAIDs such as renal insufficiency. Colchicine is used in those who cannot use either NSAIDs or steroids. Side effects. Colchicine, high dose, gives diarrhea and bone marrow suppression, neutropenia. Chronic management. Management between attacks prevents recurrences. 1. Diet. Decrease consumption of alcohol, particularly beer. Decrease high purine foods such as meat and seafood. Lose weight. 2. Stop thiazides, aspirin, and niacin. Use losartan first for hypertension. 3. Colchicine, low dose, is effective at preventing a second attack of gout. Colchicine is also effective at preventing attacks brought on by sudden fluctuations in uric acid levels due to probenecid or allopurinol. 4. Allopurinol decreases production of uric acid. Febuxostat is used if allopurinol is contraindicated. Febuxostat is a xanthine oxidase inhibitor. Probenecid, lesinurad, NSAIDs, and sulfenpyrazone are contraindicated in renal insufficiency. Allopurinol is safe with renal injury. Pegloticase dissolves uric acid. Uric acid metabolism is accelerated by pegloticase. Probenecid and sulfenpyrazone increase the excretion of uric acid in the kidney, uricosuric. These drugs are rarely used. Adverse effects of chronic treatment. Hypersensitivity, rash, hemolysis, allergic interstitial nephritis, occurs with uricosuric agents and allopurinol. Colchicine can suppress white blood cell production. Toxic epidermal necrolysis or Stevens-Johnson syndrome may occur from allopurinol. Do not start uricosuric agents or allopurinol during acute attacks of gout. If the patient is already on allopurinol, you can safely continue it.